Today we're going to talk about a couple of foregut topics. We're going to talk about peptic ulcer disease, gastroesophageal reflux, and paraesophageal hernias. My name is John Rodriguez. I'm a minimally invasive surgeon at the Cleveland Clinic. I have no relevant financial disclosures for this talk. I do have some consulting and research funding that, as I mentioned, is not going to be relevant to these topics. And the objective for this talk is to review diagnostic and therapeutic modalities that are relevant for management of peptic ulcer disease, gastroesophageal reflux, as well as paraesophageal hernias. So we're going to start with peptic ulcer disease. And just to mention a couple of things, this is a rare disease in modern day medicine. The prevalence has been slowly decreasing over the past century. There's a lot of different factors that play a role into it. One of them is improvement in medical therapy. But what we really see today is more peptic ulcer disease associated with two major risk factors, being H. pylori infection as well as use of non-steroidal anti-inflammatory medications. So when you look at the prevalence of patients that come in with peptic ulcer disease who get tested for H. pylori, depending on what part of the world you look into it, the incidence of H. pylori infection can be as high as 90%. So it's a little bit higher in Eastern countries, but here in the US and some of the Western countries, it's about 50 to 60%. So basically every patient that comes in with active peptic ulcer disease should be tested for H. pylori infection. There's many different ways to do this, and the most common way, especially with the patients being worked up with endoscopy, is to do a biopsy during that time and either run it for pathology with proper staining or do a rapid urease test. In those patients that are not getting endoscopy, the most cost-effective method to try for H. pylori is to use a stool antigen test, which can have both a sensitivity and a specificity over 90%. Urea breath testing is another good method of doing it. The problem is that it's not readily available. It does require some radio leveling for it to be performed. So it's not available in every institution that you're going to try to do this. So in that sense, the stool antigen test ends up being a better and most popular method for testing for H. pylori. In terms of NSAID use, the FDA estimates that there's about a 1 to 4% year risk of clinically significant GI events in patients who are taking NSAIDs. And we have to remember that when we look at NSAIDs, it's not just patients that are taking NSAIDs for management of pain or other inflammatory diseases. It's also patients that take aspirin for cardiovascular reasons. So there's a subset of patients who are going to be at risk of peptic ulcer disease related to NSAID use. And those are the ones that have a prior history of peptic ulcer disease. Not every medication is the same. There are some anti-inflammatories that have a stronger effect in terms of developing peptic ulcer disease, and also the duration of therapy is going to play a role. And those patients with an age over 75 are also going to be at a higher risk of peptic ulcer disease when taking NSAIDs. In terms of the presentation, most of the patients are really asymptomatic, about 70%. But those that do develop symptoms, dyspepsia or that kind of epigastric discomfort is probably the most common symptom. In those patients that develop duodenal ulcers, the classic description of the duodenal ulcer pain is pain that happens typically about 2 to 5 hours after a meal. And that usually happens when that buffer effect of the food bolus goes away, so patients are exposed to a higher acidity in the duodenum. But really, the vast majority of patients that we are going to see in our surgical practice are those presented with complications. And usually when we talk about complications, the most common ones are going to be bleeding and perforation. Penetration can also happen, but this is a bit more rare. So those patients that are coming in either with symptoms or patients that are coming in with complications who are getting evaluation, endoscopy has really become the best test for evaluation of peptic ulcer disease, and it can also be the best treatment for acute complications, especially in cases of bleeding. Now, when you look at detection rate of peptic ulcer disease with endoscopy, the sensitivity is going to vary highly by the location and the experience of the endoscopist. So some of the ulcers that located in the duodenal bulb can be a little bit more challenging to find versus ulcers located in the stomach and kind of more distal aspects of the duodenum. When you look at the typical appearance of these ulcers, the typical benign ulcers are going to have this regular appearance and the smooth edges that you can see in the pictures below. So you can see ulcers in a couple of different locations. On the extreme right, you can see an ulcer hiding in the duodenal bulb. In the middle, you can see a gastric ulcer along the lesser curvature of the stomach. And on the left hand, you can see another duodenal ulcer a little bit more distal. Now, one of the big topics that always comes up is, who should get a biopsy during endoscopy? And I think most endoscopists will agree that those ulcers, especially in the duodenum, that are benign appearing do not need to be routinely biopsied. So if you see a typical ulcer with the nice smooth edges and the flat base, those usually do not need to be biopsied as long as they're in the duodenum. But gastric ulcers do present a little bit more controversy. Part of it is because of the risk of hiding gastric cancer. So anytime you see a suspicious gastric ulcer, and those are ones that are going to be a little bit more irregular, that are going to have the raised edges, as you can see on the right, those should undergo 4-quadrant biopsy to rule out the possibility of a malignancy. Now, in terms of the ulcers that are a little bit more benign appearing in the stomach, it's a little bit more controversy. I think in general, I tend to biopsy them more than not. So you're never wrong with biopsying them, but not for the duodenal ulcers. So moving forward and talking a little bit about complications, which is going to be a little bit more relevant in our surgical practice. There has been a significant fall in the number of hospital visits due to complications from peptic ulcer disease over the last 20 to 30 years. And it's about a 40% decrease in these presentations. When you look at those patients that do come in, the vast majority of them are going to come in with a gastrointestinal bleeding, and that's about 73% of them, which is more common than perforation or obstruction. When you look at the impact of this disease in terms of the morbidity and mortality, there's about a 10 times higher mortality rate with patients presenting with complications of peptic ulcer disease when compared to other common diseases like acute appendicitis or acute cholecystitis. And the 30-day mortality specifically for perforation is about 24% and bleeding is about 9%. So really, when they do present, they can be pretty devastating. And one of the common and the important things to realize, who are those patients at risk of having a poor outcomes? And one of the initial kind of assessments of these patients is going to base on the physiologic impact that this complication is having on them. And there's many different ways to look at this, but some of the more recent articles have looked at using the Apache 2 score as a predictor of mortality for these patients. So those patients who have a much higher physiologic impact, whether it's due to hypotension, tachycardia, fever, increased respiratory rate, and overall acidosis, and some of the other factors that we do measure are going to do worse than those presenting early on who are still hemodynamically stable. So patients that have active bleeding at presentation, those patients who present with perforation and are not intervened in an early fashion. So usually when there's a delay of more than 12 hours, those patients tend to not do well. And patients who are malnourished, which is common to see in patients presenting with gastric gullet obstruction from pyloric channel ulcers, tend to also do poorly when requiring any kind of surgical intervention. In terms of the management, specifically for patients presenting with bleeding ulcer, the most important thing is to follow the principles of resuscitation. So these are patients that need to be aggressively resuscitated. So obtaining proper IV fluid resuscitation, blood transfusion as needed, and also establishing early PPI therapy. And there's a little bit of controversy in terms of the effectiveness of IV over oral, but for kind of the main principle, those patients presenting acutely should be placed on IV PPI therapy And the most common way to administer this is through an IV infusion. When patients undergo endoscopy, there are certain tools that can help us predict the risk of rebleeding and the need for additional intervention, and that is based on the Forrest classification that you can see here in the chart. So those patients that present with active bleeding, whether it's an active kind of squirting vessel or oozing, are going to have a much higher bleeding rate. It can be as high as close to 100% in some series, versus those patients that present with a known GI bleed who have a non-bleeding visible vessel that can be treated, patients with an adherent clot, or just a flat spot in the ulcer crater. And that goes all the way down to Forrest type 3, who are those who are going to have a clean base ulcer that have a very low rebleeding risk. So having said that, it kind of brings up the topic and the role of endoscopy. So as I mentioned before, endoscopy has become really the mainstay of both evaluation and treatment of peptic ulcer disease, and mainly for GI bleeding. And there are different ways to control active bleeding, and I'm going to try to go over some of them. So in this picture, you can see a couple of different thermal devices that can work by two different types of mechanism, either the contact devices, such as different multipolar and bipolar commercially available devices, the heater probes, and also hemostatic graspers that can be used to grab a vessel and cauterize it, all the way to those with non-contact, like the argon plasma coagulation, that works very well for very superficial mucosal bleeders. In terms of injection therapy, so the way that injection therapy works is really by tamponade using a volume effect. So when you use just plain saline, this is the way that this therapy is going to help stop that bleeding. But most commonly, the way we see it in clinical applications is combined with pharmacologic agents such as epinephrine, in which besides the volume tamponade, it can also cause a vasoconstrictive effect. And really, in the last few years, what we've seen as a mainstay of management of bleeding has been the use of hemostatic clips. And when you look at using different modalities for management of bleeding, as a single modality, clips are going to be the most effective way to treat bleeding in peptic ulcer disease. And on the left, you can see a couple of different commercially available hemostatic clips that vary by size and their opening angle. They all work kind of in a very similar fashion. And like I said, they're very effective for treating active bleeding. And on the right, you can see some of the newer generation over-the-scope systems that can be used to treat refractory bleeding or some more challenging vessels that require a much bigger tissue purchase. So what happens, or how do we define persistent bleeding in those patients that underwent endoscopy and who had intervention done for bleeding? So when you look at those patients that continue to have either hematemesis or a bloody nasogastric tube output more than 6 hours after a therapeutic endoscopy, that is consistent with persistent bleeding. Patients in whose stool has normalized but then follows again melena or hematochezia, that's also another indication of persistent bleeding. Tachycardia or hypotension more than 8 hours after presentation, or 1 hour after obtaining hemodynamic stability by aggressive resuscitation, is going to be a red flag. A hemoglobin drop of more than 2 grams after 2 consecutive stable counts is also considered persistent bleeding. And a hemoglobin drop of 3 grams over a 24-hour period with persistent signs of bleeding, such as melena and hematochezia, are also going to be raising a red flag for ongoing bleeding. And these patients do require a kind of a different management strategy and a bit more aggressive management, but the first line continues to be a repeat upper endoscopy. So if the patient had a successful endoscopy and looking at that force, they did have a risk of rebleeding, and now they're developing that kind of rebleeding syndrome, they can be rescoped, and sometimes they can be successfully treated with this route as well. But those that fail endoscopy, or those that have factors that are going to be predictors of a high rebleeding risk, such as big, deep ulcers, they may need additional therapy. And there's been a trend over the last few years in terms of what that next step is between surgery for an active bleeding versus interventional radiology with transarterial embolization. So some of the most recent data that has compared surgery with interventional radiology and embolization really have shown a comparable effectiveness in expert hands with a lower morbidity when compared to surgery. They're both going to have a failure rate close to between 7 and 10%, but it does happen with surgery as well, where you take a patient to the operating room to control bleeding from an ulcer and the patient rebleeds. I think the most important factor to consider when deciding between interventional radiology versus surgery as the next approach is going to be based on the expertise of both the surgical team as well as the radiology team and the available resources that are going to be present at each individual institution. So in terms of surgery for some of the other complications in active bleeding, which is a little bit of a complex topic to cover today, I just want to mention that most of the operations that we do nowadays in referral centers are based on complications such as refractory ulcers and patients who present with gastric outlet obstruction from pyloric stenosis due to these chronic fibrotic inflammatory ulcers. And those patients will require a combination of an anti-acid operation by either trunk or selective vagotomy, as well as antrectomy with reconstruction. In my practice, I usually use a gastroduodenostomy or Billroth 1, which can be done laparoscopically, and we do most of them laparoscopically over a loop gastrojejunostomy, or preferably in most of these patients, a Roux-en-Y reconstruction is going to have excellent results as well. So changing topics a little bit, let's talk about gastroesophageal reflux and hiatal hernias. So gastroesophageal reflux is probably the most common GI disorder affecting the esophagus. And when you look at the prevalence in the Western world, up to 20% of patients will have GERD. It represents close to 9 million outpatient visits in the US, and protein pump inhibitors has become the most common and popular treatment for this disease. To define GERD, we have to understand what the background is, and a group of experts published the Montreal Consensus, and they define GERD as a condition that develops when the reflux of gastric contents causes troublesome symptoms and or complications. So there are two different components to this. One is there actually has to be reflux of gastric contents into the esophagus, and two, the symptoms must be bothersome or must result in a complication. So PPI has really revolutionized the treatment of gastroesophageal reflux disease. And going back in time, in the 1970s, is when the hydrogen potassium ATPase pump was initially described as a final step in acid production. And in the late 1980s, omeprazole was launched as the first protein pump inhibitor. And less than 10 years later, the pharmaceutical company Losec became the biggest ever selling pharmaceutical in the history of medicine. So that just kind of shows you the popularity and the impact that PPIs have had in the management of such a common disease. Looking at surgery, so at the beginning of the 21st century, we did notice a significant decrease in the number of operations being done for management of reflux. And over the past 10 years or so, we've seen the number come slowly back up. And part of it has been due to the concern of using long-term protein pump inhibitors, and some of the newer media publications looking at some potential risks of long-term PPI therapy, which have really caused a bit of a panic in those patients that have been taking these medications for a long time. So the interest in surgical intervention has increased. But to be critical about what we can do and kind of looking a lot of the treatment options, we have to understand that those patients that have optimal medical therapy and lifestyle modifications, you're still going to see about a third of them who are going to have persistent symptoms despite being on high-dose PPI therapy and following proper lifestyle modifications. But the opposite to that is those patients undergoing anti-reflux surgery, such as a Nissen fundoplication, there's going to be about a 20 to 30% of patients that are also going to fail proper symptomatic management. And those that have surgery, about a third of them will go back on protein pump inhibitors even after surgery. But when you look at quality of life and other measurements and patient satisfaction, most of these patients, up to 90%, would go through surgery again. So even though no intervention is going to give you a 100% chance of symptom control, and I think it's always important to have this discussion with patients, is that GERD is a chronic disease with a high recurrence rate and a high long-term failure of any option that you offer different patients. So I think it's important to set expectations right with these patients and make a decision together about what the best treatment strategy is going to be for any set patient. When you look at a diagnosis, so the diagnosis is primarily clinical, and most of the time, a medical trial with PPI therapy is an acceptable way of diagnosing and treating gastroesophageal reflux disease. In those patients that have worsening symptoms or have any concerning symptom for a complication such as dysphagia or poor symptomatic control, I think one of the mainstays is an upper endoscopy to look for objective proof of reflux. So when you are considering a patient for surgery, that is one of the main things that you need to prove is that there's objective reflux happening. So you need to prove that there are contents from the stomach coming back into the esophagus. And you can do that by two different ways, either by proving that there's some sort of anatomic alteration, either the presence of esophagitis, a peptic stricture, or in some extreme cases, Barrett's esophagus, found in endoscopy, is enough evidence that there is gastroesophageal reflux disease. But in those patients where upper endoscopy does not reveal any of these findings, the best way to define that is through a pH study, whether it's a wired 24-hour or some of the newer wireless approaches that can be done for anywhere between 48 and 96 hours. You need to document objective reflux. So like I mentioned, I think endoscopy is probably one of the most informative tests. It can help you define anatomy. It can show you the presence of a hiatal hernia. It can show you complications. So usually we do that as a first test. pH study, like we mentioned, and in some cases you need to consider impedance, because one of the limitations of some of the wireless options is that they cannot detect any pH above 4. So if you're concerned about non-acidic reflux, doing a wired pH study to measure impedance is going to be a better option. In some of those patients where you need to define anatomy, either because they have a hiatal hernia, an upper GI barium study is probably the most informative test. And also in some patients undergoing consideration for surgery, doing an esophageal manometry to rule out any sort of esophageal dysmotility is very important, especially when considering a fundoplication. And I routinely perform gastric emptying studies in my patients prior to any kind of fundoplication to rule out the possibility of gastroparesis. So this table shows you some of the pros and cons of common diagnostic modalities being used for gastroesophageal reflux disease. So looking at, one of the first things we mentioned was using the PPI therapy as both a diagnostic and therapeutic alternative, is that there's really no standardization of what the initial dose or duration of therapy is. And defining the response is not standardized, so some patients will be complete responders versus others being partial responders. So it is a very easy and non-invasive and inexpensive way to diagnose GERD, but it will have some limitations. In the same fashion, endoscopy is going to be invasive and it's going to require sedation in the vast majority of patients. And when you do have a normal endoscopy, which you will in about 2/3 of patients undergoing evaluation for reflux, it does not rule out reflux. It just shows you that there's no significant anatomic alterations in the esophagus. In terms of some of the objective reflux monitoring, like we talked about, catheter-based pH is still considered by most the gold standard for diagnosis. But one of the biggest limitations, and especially now that patients are aware that there are some wireless options, is that catheter discomfort is going to be a major limitation for patients having a normal diet and following their daily activities, which can have an impact in reflux. Wireless pH is better tolerated, and you can monitor for a longer period of time, but it is more costly, and it does require an endoscopy for placement. And like I mentioned before, it typically does not detect any pH above 4. What about treatment? So treatment is really based on each patient, and I think these discussions need to be had in terms of both the pros and cons of medical therapy, surgical therapy, and some of the newer endoscopic alternatives for management of reflux. But in general, some patients will have a very clear benefit of surgery. So those that have failed medical management, so patients that had good symptom control and now their symptom control is not as good despite optimal lifestyle modifications and medical management. Patients who take an informed decision towards surgery, those patients that do develop GERD-type complications, mainly peptic strictures and Barrett esophagus, are going to benefit from them, as well as those that have large hiatal hernias and are very symptomatic. And extraesophageal manifestations, which can happen, tend to have a better response to surgical intervention than to medical therapy. So those patients also benefit from surgery when compared to medical management. So when you look at anti-reflux surgery, this is probably one of the most controversial topics in foregut surgery. And for the most part, historically, it's been based on the surgeon's preference and expertise. There are many controversies regarding techniques, but in the last few years, there's been a strong effort towards standardizing techniques for anti-reflux surgery. So talking about fundoplications, what we're going to be looking at is the degree of fundoplication, which is going to be a balance between reflux control and the risk of dysphagia. So on the upper right, we see a complete 360-degree fundoplication, also known as a Nissen fundoplication. On the bottom right, it's a 270-degree posterior fundoplication, which is also known as a toupee fundoplication. And on the lower left, you're going to see the anterior 180-degree fundoplication, also described as a door fundoplication. And these three are the most common fundoplications done for patients undergoing these type of foregut operations. So in terms of some of the controversial topics, the approach, whether it's laparoscopic or open, partial versus complete wraps, and what to do in some spatial populations is what I want to cover in the next few slides. So looking at the debate about laparoscopic versus open, and having said this, there's still a very good number of fundoplications being done open in the United States and other developed countries even up to this day. But there's been significant level 1 evidence that has shown that those patients that have a minimally invasive approach have a 65% lower morbidity than those undergoing an open approach. There's also a much shorter length of stay with the laparoscopic approach, and the return to activities is significantly shorter as well. So a clear benefit in laparoscopy versus open technique for construction of fundoplications. In terms of the degree of fundoplication, there's been about 9 randomized controlled trials that have looked at a posterior 270-degree or toupee fundoplication versus a posterior 360-degree Nissen fundoplication. And there's a bit of a conflicting evidence in terms of reflux control. So there's no clear winner here, with a tendency towards better reflux control in some studies with the Nissen compared to the toupee. But the counterpart of that is that there's a tendency towards less dysphagia with the toupee than with the Nissen fundoplication. But what most people agree on is that the technical aspects that are considered for construction of any of these fundoplications are probably the most important um, tool in terms of the risk of dysphagia and proper reflux control. So what we agree on as a technical aspect is a Nissen fundoplication should be short and floppy. And I'm sure that those of you that scrub and participate in these operations are going to commonly hear attending surgeons say, you know, the Nissen has to be short and floppy. And what that means is that the Nissen should be constructed by approximating the greater curvature of the stomach in the fundus to that tip of the fundus after it's being mobilized or not. So that will allow the maximum circumference of stomach coming around the esophagus. And when you secure the Nissen to the esophagus, the length of stomach being secured should really be less than 3 centimeters. And what some data has shown is that the risk of dysphagia using a 1.5 or 2 centimeter wrap is significantly lower than those 3 centimeters or above, with no clear difference in reflux. So that's what we mean when we say short and floppy. So it's got to be a short construction, and you have to use the entire circumference of the stomach. So one of the common mistakes that we see is either using the anterior gastric wall or using the body of the stomach to approximate to the tip of the fundus, which will result either in a tight wrap or an improperly constructed wrap. Now, the opposite is true with the toupee. So for the toupee, longer is better. So when you look at the length of the stomach being secured to the esophagus, you're going to see better reflux control when the toupee is 3 centimeters versus a short wrap of 1.5 centimeters. And there's really no difference in dysphagia using either a long or a short posterior 270-degree fundoplication. What about obesity? So you can't really discuss this topic without bringing the obesity epidemic that we're experiencing, and there's a very strong association between patients who have reflux and those that have obesity. And when you look at some of the data looking at the success rates of fundoplication in those patients with obesity, either class 1 or class 2 obesity, there's a significantly higher failure rate in those with the body mass index above 30. So some of the tendency and the evidence has supported this is that Roux-en-Y gastric bypass is probably the best treatment of gastroesophageal reflux disease in patients who have obesity. And there's a couple of rationales for this, and one of the main things is to understand that when you construct a gastric bypass and you create a small gastric pouch, you are separating the vast majority of the acid-producing cell of the stomach away from that esophagus. So really that acid that is still being produced in the stomach should have no way to reflux back into the esophagus, because it's most of it is going to be in that remnant stomach. Also, patients who have obesity, reflux is rarely going to be an isolated problem, and it's usually going to be more related to a stronger association of weight-related comorbid conditions such as the metabolic syndrome. So when you are doing bariatric surgery and mainly a gastric bypass for these patients, you're not just treating the reflux, you're really treating the underlying problem, which is obesity and some of the weight-related comorbid conditions. So as you can see here, these are probably two of the most common operations done for metabolic purposes in the United States. On the right-hand side, you're going to see the sleeve gastrectomy, which is actually not a good treatment of reflux. And some of the newer data on sleeve shows that reflux after sleeve can be very debilitating, and it has become one of the most common reasons for revision of these operations. So there's a high incidence of new onset reflux in patients who have sleeve gastrectomy, close to about 20%. But on the left-hand side, you see the anatomy of a Roux-en-Y gastric bypass, and as I was describing before, separating that parietal cell mass from having any sort of access to the proximal esophagus is going to play a key role in controlling reflux for these patients. There's also a number of patients are going to have esophageal dysmotility that is diagnosed on preoperative esophageal manometry. And there's a notion that fundoplication should be tailored for these patients. So the common perception is that patients who have esophageal dysmotility should not undergo a complete rep. But when you look at some of the publications that have come out in the last few years, there is growing evidence that preoperative and postoperative dysphagia in these patients do not really correlate. So I think technique and proper patient selection is probably going to be the most important factor when you select these patients for anti-reflux surgery. In some of these cases, and we've really moved towards this approach, is that doing a gastric bypass, not for the notion of metabolic impacts or weight loss, but just as a parietal cell separating or a gastric partitioning procedure, can be very effective in some patients who have very severe dysmotility, or those with connective tissue disorders such as scleroderma, who not just have esophageal dysmotility resulting in reflux, but are also at high risk of aspiration and other complications. So looking at the outcomes of surgical intervention, typical symptoms have excellent response. Even though there's no level 1 evidence showing that Barrett's goes away after anti-reflux surgery, there is significant evidence that shows that there can be improvement, and in some cases even regression of Barrett's when proper reflux control is achieved. And like I mentioned before, atypical symptoms are going to respond better to surgery than to medical therapy. So connecting this talk about reflux to anatomic defects, some like paraesophageal hernias, I think it's important to understand that most of the anti-reflux mechanisms are not only related to the functionality of the lower esophageal sphincter, but there's also significant anatomic components that play a huge role in as an anti-reflux barrier. And we talk about the paraesophageal ligament, the integrity of the muscle fibers and the gastroesophageal junction in the abdomen, and the angle of His as a mechanism of having a flap valve that protects the esophagus against reflux. And those barriers are typically going to be completely disrupted when you have a hiatal hernia. And looking at the types of hiatal hernias, there's going to be 4 types of hiatal hernias, with type 1 being the most common, which is really just what we define as a sliding hiatal hernia, where the gastroesophageal junction tends to move, cephalad and caudad, either with inspiration or just spontaneously through the diaphragm, which results in pretty much disruption of some of the normal anatomic barriers. In a type 2, which is a true paraesophageal hernia, typically the gastroesophageal junction is at the level of the abdomen, but you do have some component of stomach herniating right next to the esophagus into the chest. Type 3 is really a combination of type 1 and type 2, where you have both a significant amount of stomach herniating up into the chest, but also a gastroesophageal junction that is going to leave in the chest and not the abdomen. And a type 4 is just the presence of any other organ or viscera within the contents of that hernia sac. So most of these patients, what they will have are going to be GERD symptoms. So especially in those with type 1 and type 3 hiatal hernias, they're going to have GERD symptoms such as heartburn, regurgitation, and dysphagia. But some of the patients with larger hiatal hernias, and typically as you have a larger component of the stomach up in the chest, they're going to develop obstructive symptoms, which can be very debilitating and also concerning because of the risk of gastric volvulus. So things like chest pain, early satiety, nausea, and retching are all red flags for obstructive symptoms in patients with hiatal hernias. And in some extreme cases where you have a significant amount of either the stomach or other intra-abdominal organs causing a mechanical effect against the lung, it can result in respiratory complications from poor lung expansion. And as the stomach kind of herniates through a very mobile part of the body with the diaphragm just moving up and down every time we breathe, the development of ulcers in that area, which have been described as Cameron ulcers, can also be of concern because these can bleed and they can result in anemia, especially in elderly patients who've had hiatal hernias for a long time that have not been diagnosed and treated. So when you do surgery for hiatal hernias, there are principles that we agree on that should be done in every single operation. So we talk about a complete mediastinal dissection, which means you have to really identify the hernia sac, dissect it away from the diaphragm, and completely reduce the sac and its contents back into the abdomen. Excision of the sac is not always necessary, but especially when constructing a fundoplication, I think it's important to excise the sac to avoid that bulkiness getting trapped in your fundoplication, and it also helps you identify the edges of the stomach a little bit easier for proper stitch placement. We also talk about adequate esophageal length. So after mediastinal dissection, there should be at least 3 centimeters of esophagus in the abdomen in a tension-free manner. So most of us that do perform these operations like to place some sort of handle on the esophagus to manipulate it as we dissect this. And what I typically do is place a Penrose around the esophagus. So to be able to measure this, you have to release the tension on the esophagus and make sure that you have that amount of esophagus in a tension-free manner in the abdomen. The crural closure should be performed adequately, and we'll talk a little bit about that. In a fundoplication, which there is both data supporting fundoplication as part of a hiatal hernia repair, as well as some newer data showing that it is not always necessary. A well-constructed fundoplication is a key part of a good anti-reflux and hiatal hernia operation. So let's address some of these controversial topics that have been described, both for closing the defect, placement of mesh for reinforcing the hiatus, esophageal lengthening procedures, and what to do in patients with obesity. So for defect closure, I think the choice of suture should always be non-absorbable, whether you use braided or non-braided, or you place figure of 8s or simple or run it. It should always be done with a non-absorbable suture. There's really no good evidence supporting one technique over the other, whether we're using simple interrupted, figure of 8s, or running. But we found that running barbed suture, which has become commercially available in the last few years, can be very helpful in some challenging defects, especially as you advance more on that left cruise. Performing a left cruroplasty can help even the closure, because when you look at the anatomy of these hernias, most of the time what you're going to see is a very straight right cruise, but a very bowed out left cruise. And one of the things that I'm always very critical when I'm training other people on how to do this is to avoid creating a step on that posterior closure. So as you lift up on the esophagus to close the defect posteriorly, if you overdo that closure, you're going to create an angulation at the esophagus as it enters the abdomen. And that can cost dysphagia postoperatively and can be a real nuisance for patients. So usually what I do is that I will perform a posterior closure until the esophagus is in a neutral position, and if there's still a defect, then I will complement that with anterior crural closure. In terms of mesh, this is one of the commonly debated topics when addressing surgery for hiatal hernias, and most of the evidence, especially one of the randomized trials published by Dr. Ulcer, shows that the risk of short-term recurrence is lower when placing mesh in the hiatus, but there's really no difference in the long-term recurrence for these patients. The tendency, especially in Western countries, is to use either biologic or bioabsorbable materials over synthetic mesh. There's a huge cost variability between some of these materials, especially with some of the biologics and some of the synthetic bioabsorbable meshes. So in my practice, I usually use a bioabsorbable synthetic mesh. And again, I think one of the key things when we look at this and decreasing the risk of complications, and mainly talking about fibrosis around the esophagus, which can result in dysphagia, or talking about mesh erosion into the esophagus, is to avoid encroaching the esophagus. I think really what the mesh should reinforce is the hiatal closure and not necessarily be wrapped tightly around the esophagus, because I think that's just asking for trouble. In terms of fundoplication, like I mentioned before, it has been described as a critical component in paraesophageal hernia repairs, but it's also a common culprit for need of reintervention. You have to remember that we're dealing with a disease process that has a very high recurrence rate. So when you look at the anatomic recurrence of hiatal hernias, in most series, it's about 40 to 50%, regardless of the approach. But the risk or the need for a reintervention because of recurrence is very low, with a 10-year accumulated risk of about 7%, looking at some of the most recent series. So really, it's common to see an anatomic recurrence, and most of these are found incidentally during imaging studies, but it's rare to have to do an operation because of recurrent symptoms or recurrent complications from hiatal hernia. But like I mentioned before, I think when you do a fundoplication, a poorly constructed rep can be a cause for reintervention, and it's also a common cause of poor functional results. Looking at the data, again, supporting fundoplication, there's one recent randomized control study that shows better reflux control postoperatively when performing a fundoplication versus not. In terms of gastropexies, theoretically, there are two different functional impacts of the gastropexy. It can either help prevent the recurrence, which really no data has shown this in a significant manner, or it can prevent the risk of volvulization in case of a recurrence. But again, there's no really real significant data supporting this practice. In some patients who are very high-risk patients who are taken emergently to the operating room, it has been described as a sole procedure to kind of tack the stomach down, either by placing stitches or sometimes either placing gastrostomy tubes to keep the stomach in an intra-abdominal position and avoiding volvulization. In terms of esophageal lengthening, the short esophagus has been really recognized as a common culprit of recurrence, and performing esophageal lengthening procedures such as a Colles gastroplasty should be strongly considered when the length of esophagus is inadequate. Now, these operations are somewhat challenging to perform laparoscopically, and there's a couple of different techniques. In the upper right technique, you can see the use of the circular stapler to create a small circular orifice in the stomach to then advance a linear stapler up to that gastroesophageal junction in a very common way as it's done open, and this again can be done laparoscopically under expert hands. And in the lower right hand side, it's a modification of the Colles, which requires a wedge fundectomy, which is much easier to perform laparoscopically than the EA technique. They can both be considered, and again, with proper training and expertise, they're fairly straightforward to do. Obesity, like we mentioned before, is a major risk factor for recurrence after hiatal hernia. There's been a growing body of evidence showing that performing a paraesophageal hernia repair and concomitant bariatric surgery is very safe. The risk of complications of the two operations combined is really no higher than each of them separately. The tendency for most surgeons performing these operations is to perform a bypass because it does have a better reflux symptomatic control versus the sleeve. But sleeve has also been done, especially because we face significant insurance hurdles and patient and cultural hurdles when we try to select these patients for surgery. So that's probably one of the most common issues that we find in our practice, is that the barriers for application of these operations is really limiting the benefit for a lot of these patients. So in summary, what we can say about these topics relevantly is that peptic ulcer disease in this day and age is mostly related to either non-steroidal anti-inflammatory use and H. pylori infection. So these two factors should be considered in every patient presented with peptic ulcer disease. Interventions are more focused on complications, and most of these are endoscopic. Again, it's rare in this day and age to be performing operations for either complications of peptic ulcer disease or either emergent interventions. Gastroesophageal reflux disease and anatomic abnormalities such as hiatal hernias are very strongly related, and patients who are undergoing surgical evaluation should have proper functional workup done to make sure that you're treating the right disease. So make sure that this is reflux and it's not something else like gastroparesis or functional dyspepsia, because those patients will have a very poor outcome. Especially if there's a hiatal hernia, make sure you define the anatomy and make sure you're prepared to do whatever is necessary to give the patient the best possible outcome.